Welcome and thank you everyone for joining this session, which is going to focus on population health management, tackling cardiovascular disease and healthcare inequalities in England. In a minute, I'm going to be introducing three speakers who are really going to share their insights into this topic. But first, just to say, this is a session run by the Accelerated Access Collaborative and working with the academic health science networks. One thing I do want to note is we will be discussing a product called Inclisiran, which is currently undergoing NICE review, not yet authorised by NICE, but this is being used as an example of where a population health management approach can be used to ensure rapid access to new therapies. So it's an example for us. So I'm delighted to be able to welcome three great speakers today. I'm joined by Professor Julia Newton, who's Medical Director for Health Improvement Programmes at North East and North Cumbria AHSN. Also by Dr. Tracy Bell, Medical Director for Health Innovation Manchester, and also Executive Lead for Primary Care at Greater Manchester Health and Social Care Partnership. And by Matt Kearney, who's Programme Director at UCL Partners and also former National Clinical Director for Cardiovascular Disease Prevention. These speakers are going to share great insights into their experience of taking a population health management approach. And first, I'm going to pass over to Matt Kearney, who's going to take us through an introduction to cardiovascular disease and health inequalities.
And thank you, Helen, and it's great to be here joining you all today for this important discussion. So we know cardiovascular disease is very important. It's responsible for 1 in 4 premature deaths. It's very expensive for the health economy, costing about £7 billion a year in England, and with much larger, wider socioeconomic costs, around about £15 billion a year. But it's also cardiovascular is a major contributor to health inequalities. And we know that it's responsible for about 1/4 of the life expectancy gap between rich and poor. Cholesterol is an important risk factor for cardiovascular disease. It's present in about 1/3 of people with high cholesterol, is present in about 1/3 of people with coronary heart disease. We know that it causes this disease, but we know the treatment is very effective at preventing cardiovascular disease. But despite that, suboptimal treatment is very common. Atrial fibrillation and high blood pressure are two similar high-risk conditions for cardiovascular disease, where treatment is very effective, but where there is similar substantial underdiagnosis and undertreatment. And it's for that reason that the long-term plan that we published in 2019 focused on optimizing diagnosis and treatment for the ABC, AF, blood pressure, cholesterol, with the ambition to prevent 150,000 heart attacks, strokes and cases of dementia, knowing that we could actually achieve this population health ambition, this huge ambition, just by focusing on optimal care in those 3 conditions that include cholesterol. So it's very exciting that we've got new drugs, but it's critical to understand, and this was at the heart of the long-term plan approach, critical to understand that the arrival of new drugs or new guidance is not enough. Even with existing effective therapies, we know that there is suboptimal management at every stage in the lipid pathway. So in secondary prevention, for example, people with pre-existing cardiovascular disease, we know that about half of our patients are on no lipid modifying therapy or on suboptimal lipid modifying therapy. With PCSK9 inhibitors, a fantastic a couple of drugs, we know that most patients who are eligible for these drugs are not receiving them. In primary prevention, the majority of people who have a cardiovascular risk score above 20% in 10 years are not on statins. And for many people with a high cholesterol without pre-existing cardiovascular disease have never had a cardiovascular risk score done. We all know in primary care that lifestyle advice is core to preventing CVD in people with a high cholesterol, but we know that we provide that inconsistently. And finally, familial hypercholesterolemia, this major condition that causes severe cardiovascular disease at a young age and deaths at a young age, but 92% of people with this condition are undiagnosed, and we often do not investigate high cholesterols in primary care. So the reason for this, though, is that following the guidance, which is clear, and optimizing treatment for cholesterol and the other high-risk conditions in the real world is difficult. In our brief 10-minute consultations, time pressured, with patients usually having one or more comorbidities, starting to talk about cholesterol reduction, giving patients statins, suggesting statin therapy, we know that causes a lot of anxiety for patients. There's a lot of negative coverage in the press. We don't often have the time to do proper shared decision-making consultations in these high-pressured times with our patients. And often we're uncertain about the dosing in particular patients, the intensity of drugs to use, and the place of the new therapies. So these are the real-world challenges that stop us in real-world primary care putting guidance into place and using new drugs. So it's in response to that and thinking about the long-term plan ambitions, how do we implement them in the real world? In UCL Partners, we've developed, we've taken a population health management approach to this. So using data to understand what is driving high levels of cardiovascular disease in some of our communities, stratifying the populations to understand better how can we deliver care where it's most needed, what interventions will make a difference, and how can we adapt our services so we deliver more tailored, proactive care to our patients in a way that works in the real world in primary care. So the proactive care frameworks that we've developed by GPs and pharmacists in primary care, focus on how do we optimize long-term condition management in this new world post-COVID, where so much has changed in general practice. The frameworks focus on 6 conditions, which include cholesterol, but also atrial fibrillation, high blood pressure, diabetes, as well as asthma and COPD. They focus on data, so we've constructed searches for EMIS and System 1 that help us to stratify the patients, particularly important now as we emerge from the pandemic, because that helps us to prioritize who are the patients we need to see now, who can we safely phase for later on, and manage our workload. So for example, we know in general practice and are a bit anxious about the number of people with high cholesterol who need treatment optimization. The stratification allows us to prioritize. So let's go first, work with patients with pre-existing cardiovascular disease who are not on any therapy. And next on those patients who are on suboptimal therapy, for example. So that allows us to focus our work where the need is greatest and to manage our workload, which is critically important. And the further element of the frameworks that is quite central is the use of the wider workforce. Staff such as healthcare assistants, health and wellbeing coaches, which help patients to support remote care and self-care, support education and behaviour change. So there are lots of resources to support this. They're all free on the UCL Partners website. It includes the search and stratification tools, scripts and protocols to help staff such as HCAs deliver these consultations to support self-management. And there are digital resources, but also real-world clinical guidance. So with the patients in front of me, when should I treat high cholesterol? What drugs and doses should I choose at different times? And how should I manage the difficult things like apparent statin intolerance or raised liver function tests, for example? So in practice for patients, this would mean, so if we take a patient with, say, hypertension and cardiovascular disease, so really common, the search tools would help us prioritize. So first of all, patients who are not on lipid-lowering therapy, and then patients on suboptimal doses or suboptimal intensities, and then patients who are on maximal doses, but have poor control of their LDL cholesterol or have not had it checked recently. And then the first stage would be to optimize the clinical therapy. And we could use the hypertension framework because that also includes guidance in lipid management. And then the healthcare assistant would have a proactive care consultation by video with the patient. So linking the patient to the British Heart Foundation or Heart UK websites, which have fantastic resources to help them understand high cholesterol, understand cardiovascular risk and what they can do about it. But the healthcare assistant would also signpost to shared decision-making resources to help the patient prior to their consultation with the GP or pharmacist about whether or not they should take statins. But they could also signpost to the diet and exercise advice resources on the 1U website to personalised quit plans for the patient if they want to quit smoking, and show where to buy affordable and valid blood pressure machines and teach them how to use them in the video consultation. So the management of the patient with high cholesterol here is not just about the management of high cholesterol, it's supporting the patient in a holistic way to look after themselves and to manage their wider cardiovascular risk. So that's very much been the focus of the frameworks. They've been received really well in primary care across England, and have now been adopted by NHS England into a new national programme called the Proactive Care at Home programme. And currently 4 integrated care systems are doing an implementation pilot with a view to wider rollout this year. So I think a critical message, Helen, is that if we want to optimise lipid management, including through the optimal use of new drugs like Inclisiran, it's essential that we recognise why this is difficult to do in the real world, and that we support primary care to do things differently. So using the proactive care frameworks, I think, is as an enabler to ensure that drugs like Inclisiran actually have their full impact and deliver their potential for population health. So.
Thanks, Matt. That was a great introduction to some of the challenges we face and some of the solutions that are already out there. I want to bring Tracy in now to add to the conversation and give some of her insights into managing CVD and using a population health management approach. Tracy, what challenges have you faced and how have you delivered better care?
Thanks, Helen, and hello to everybody out there. I'm delighted to join this session. So I'm probably talking about how important population health is first in the system going forward, because in the last 100 years, we've probably seen that life expectancy has actually stopped increasing and health inequalities have widened during that time. Plus, at the same time, demand on NHS services has risen, and primary care, for sure, have been struggling with just pure disease management and access issues. And actually, much of the disease is preventable. So we've got full hospitals, we've got busy GPs, and a lot of the disease is preventable. So that's really why we want to look at population health modelling. And to do that, we have to make some changes nationally, we have to incentivise it and look at it and prioritise it. Regionally, we're moving into integrated care systems with a recent white paper to help us deliver on this and prioritise according to region. But deep down in neighbourhoods, probably the biggest change we've seen in a while is primary care networks, which are collaborations of GP practices that are the enabling unit to deliver on population health. So what is population health, this thing that you hear a lot about, and how does it come to life? Probably the most easy way to describe it is it needs to be data driven. So we need to enhance our digital and data expertise and the reporting of that deep into practices, which are really on the front line. So we've got to invest in that and give them the capability. It's very much population health, physician led. And it's a collective responsibility over a population to deal with wider determinants. So that's really important. And I'll tell you about where we've been working on that in Greater Manchester. And it really brings to light the citizen involvement that we so need in our NHS structures. So when you look at that over a primary care network, which is a small population of 30 to 50,000, you then can see it come to life. So as Matt talked about lipid profiles, you could also do it with obesity or other issues. You really drive the data into the practice to highlight the patients that are in the most need. A lot of this registered population never set foot in the NHS. And we really have to look at how do we reach them? How do we reignite communities to be talking about stuff that makes a difference in their lives and their health? In order to do this, we have to look at the other responsibilities and worries they have in their life, such as jobs, income, time, family support. All these things become secondary. So CVD health, cardiovascular health, is secondary to whether you have a house to live in, for example. So we reignite communities to act together And we need to get citizens to co-produce how they would want an intervention to be delivered, or what they think is value of the outcome you're reaching towards. In CVD, we know that there's an intervention in Inclisiran coming. So we needed to really accelerate to the citizen improvements. And how we do this is through the population health model. So we digitally drive that. We give the capacity to general practice to say, these are the cases you should be looking for. And some of those people may never arrive at your GP surgery. So that's a different model, not waiting for people to come to you, but actually actively going out seeking them, but also using community navigators, local industry, nursing staff, community staff, a real integrated team approach to delivering this. So we go and seek out people where they are. We might do these through pop-ups, mobile units. We might deliver in a different way with a wider team that is prepared to reach into that. And then we ask the citizen, really, this is an important issue. Do you understand it? Do you understand about your cardiovascular health? Do you understand what the options are out there? And that Inclisiran is just one of the many options out there. And how do we help you reduce your weight, look at your exercise, really feel better about yourself before you then look onto the medications you're taking? And that's really the approach we want to do. And we've looked at, and this is just a pipeline for how do we improve the process in the NHS to get some of the really good therapies to patients. How do we transact them in an agile way so that as soon as NICE guidance comes out, our practitioners are ready and prepared to deliver it, and we've bought it in the NHS and we have a pathway already prepared. So there's lots in that, I realise, Helen, and you can see I'm quite enthusiastic about it, but I do think we need to really incentivise population health management if we're going to survive as an NHS.
That was really excellent, Tracy. And I think what struck me is that the need for us to do a lot of the baseline work before any of these new innovations come along, because Matt highlighted, there's lots of people who haven't even had a Q risk score, who aren't on statins or aren't on the right dose of statins. And we know that's the baseline for our therapy, and everything else is likely to build on that. So lots of work we can do now to prepare, not just for this particular innovation we're talking about today, but most innovations will be built on a bedrock of good baseline care. That's how we innovate, and I think it's important that we recognise the work we can do now, really, to be ready.
I think you're absolutely right, Helen, on that. So I'm not sure we always ask our workforce. We give them targets, don't we? Do so many Q risk scores, and we target behaviour. That doesn't mean we infuse the right behaviours. I think we've got to get down into the model where we know our GPs, we know what we're working towards, and we look at the outcomes that they will drive towards, which might be bespoke for different populations where we have more inequity than others. So it might be obesity in one, it might be blood pressure in another, and it could be just simple housing and life matters in another. We really need to look with our workforce and our citizen how we reach some of these goals. So it's a collaborative rather than targeted and performance managed structures.
I agree.
Sorry, Helen. No, I just think that's really such an exciting approach that you've outlined there. And I think one of the things at the heart of it, as you say, is working with and for communities, with and for people, rather than sort of doing to them, as it were, which is historically what we do, I guess, in healthcare. And I think there are a couple of elements to this sort of population health approach. Quite rightly, you're pinpointing the wider determinants of health, these huge issues in people's lives that have a much greater impact on their likelihood of dying prematurely, of having lives destroyed by illness, such as employment and education and poverty and the environment. I think there's a real opportunity, as you say, in the primary care networks for us to get more creative about how we contribute to addressing those wider determinants by working with wider partnerships. But then there's also, as you say, supporting people to make changes in their lives, in their behaviours, in their lifestyle, helping them to understand, first of all, why that's important, but how they might do it, given the sort of existing environment that they live in. But I think there's another element to this approach, which is critical, which is, or another element to demedicalisation, and that's the democratisation of health information. So to move from a situation where you know your blood pressure or your cholesterol because I tell you what it is, and I will measure it when I think it's the right time to measure it, and then I will tell you and I'll advise you what to do about it. With so many people now having devices of various sorts that measure things and access to so much more information, I think we should really embrace that and encourage and support communities to be able to get their blood pressure checked or to get their cholesterol checked when they want to do it, so they can make their own decisions about what it means with our guidance, so that they feel part of that decision-making process. That I think that shared decision-making is much broader than just which of the drugs I tell you about will you take, but actually to understand all the information so you can make your own informed judgment. I think what you're describing is really exciting. It gives us real opportunity to start exploring some of that.
It's such a great opportunity that you've said, Matt, there, and they all have to work together, these models, and how we digitise some of the healthcare and pathways. So remote monitoring is going to be key going forward, but not that we have each patient has multiple apps. How do we combine them with a link to their healthcare record in a central place is something we've been doing, certainly in Greater Manchester. I'm sure you have been, where you work in, making it not a plethora of apps, different health apps, but actually surfacing the right remote monitoring into the right platform where all involved in your care have access to it, but equally you have in your care plan, and you can write into it the things that are personal to you. So it's a really exciting part of how we actually underpin some of the advances in the population health, and then make sure that everybody in a system can see those.
No, definitely.
Patient empowerment is so important, isn't it? We have, you know, we have 8.5 million hypertensives that we know about in this country. 2, 3, 4 of them have their own blood pressure device, and yet we're not routinely getting that data fed in a digital form that we can utilise, which actually means we end up having face-to-faces with patients that potentially we don't physically need to do anymore. So I think that opportunity to utilise patient-driven data is so important, using medical devices, but I guess over time we'll see much more of the data flowing through from wearables that people have chosen to buy, and we're going to have to deal with that and work out how we react and utilise that information, I think.
But those things, Helen, are really important that you've raised, because it reduces the demand for just monitoring situations for patients. One, it's better for patients, they can do it where they like, when they like. 2, it reduces the demand on the NHS at primary care and secondary care level, and actually that's the safe bit to do remotely. The monitoring, perhaps the safe bit, it's unsafe to do, you know, some care management remotely, but monitoring is the area where it could be digitized more safely than all contacts, for example, or all outpatients, or all everyday general practice. That's not proven to be useful both to citizen and workforce, actually. But monitoring is an area which, if we could at least take some of the workload off in that space, then we might be able to incentivise the other areas where face-to-face really matters, you know, for mental health issues, for continuity and other wider issues. At the moment, we can't do all things. So we do need to build on these foundations that will allow us to survive the busy NHS environment at the moment.
Yeah, definitely. And I would really emphasise what you were saying, Tracy, about that we don't just want a plethora of apps and devices and put them out there. And I think we've been quite good at that in the NHS. Here's great technologies, let's put it out there and make it work. And actually, that's not in anybody's interest. Technologies can really help to drive improvement, and we do need them to now that so much more has been done remotely. And as you say, there are great opportunities, but we have to take a really real world approach to it and always be focusing on the question, much less on the question, what do we need to do, but the question, how do we need to do it? And that's where we fall down often in primary care. It's the real world challenges, identifying what they are and then how we'll overcome them using the technology appropriately, because that way the technology will work for patients and for clinicians as well.
So I think we could probably keep talking about this for another 10 or 15 minutes, but I guess it's really important that we bring Julia in to give her experiences and perspective on population health management approach to improve outcomes. So let's bring Julia into the conversation now.
Thank you, Helen. I've been listening, absolutely fascinated by this conversation. And what I've been hearing is really timely, because at the moment, the Academic Health Science Network, the 15 organisations across England, are involved in implementing changes in the clinical pathway for lipid management. So we've got an AAC, AHSN National Lipid Management and Familial Hypercholesterolemia programme that really just enhances all of this change that we're describing. We're aiming to empower patients, to empower clinicians to really target management of lipids in order to help the NHS achieve those NHS long-term plan ambitions that Matt's described. One of the really exciting things that we're also doing is supporting a project that's being led by Tracy from Health Innovation Manchester, an implementation project that Tracy's going to tell us a little bit about now. So over to you, Tracy.
Thanks, Julia. So this is a really interesting implementation research. So I'll tell you some of the history. So a couple of years ago, we in Health Innovation Manchester were talking about how to be innovative in approach, not just product, with a company called the Medicines Company, which has then been acquired by Novartis. So this work has gone over 2 different companies, and it's about, initially was, how do we speed up such a really useful pharma product to adoption by the workforce in a way that's acceptable and quick to citizens in the most agile way. So how do we get it from phase 3 trials, well, there's a space till NICE recommend it or don't recommend it, but is there some things that we can do to create a pipeline to make that more agile in the time? So how do we transact the drug into primary care? How do we educate? How do we look at citizen involvement? How do we do all these many things that would make a pathway or a program successful while we've got time? So as soon as, if NICE recommended the product, we'd be ready to go and citizens could get the advantage immediately, as there's lots of things we do in the NHS that just take too much time. So that's where we started on this, and we really thought the population health model was important for the reasons that I said earlier about reaching wider determinants, looking at the way we develop this. So the actual research itself is around implementation. Of course, the drug itself has been researched in formal trials, but this is also looking at the effectiveness of the drug, but also the implementation. So how do we deliver this? Do we deliver this in practices by a pharmacist, by a nurse, by a team? How do we reach to a holistic methodology looking at patients' lives and the reasons that they may not be adherent to current therapy, or they may not have realised that there's more therapy available or more tools? So really this is in Health Innovation Manchester, the implementation research, which has taken huge part of our GM infrastructure to collectively run this and hopefully give some clues to how this could be delivered to the best way in our populations and by our populations.
That's great, Tracy, and it really does complement the work that's going on with the HSN network. What it does is it gives us information about more tools in the armoury for clinicians in order to improve how we manage cholesterol and lipids. So the HSN is working across the whole pathway, looking at treatments from statins all the way through to potentially very complex patients. So this really just gives us yet more information and raises awareness.
I'm really pleased about that, Julie, because I think the AHSNs are going to be key in something that's in the white paper, which is called provider collaboration. Everybody as a citizen in populations think that we all collaborate really well so far, but actually in reality, primary and secondary care and other parts of the health system have lots of handoffs and silos. But the AHSN with this pathway is actually providing a method for us to collaborate between primary and secondary care, start working together, reduce handoffs, and actually be more patient-centred together. So where we need to reach out for specialist advice, we can, because we'll be a team together. And where we need to deliver population health with primary care, we can, because we'll be a supported team together. So it's really exciting that the AHSNs, of which Health Innovation Manchester is part, are really driving this forward.
I do very much agree with that, and I think it's very welcome work that the network's leading. It's great that it's a comprehensive programme and that you're taking a whole pathway approach, Julia, and that you're very much taking this population approach to it. And I think it's great that all the AHSNs are contributing to that, because we know that cholesterol has very much been a Cinderella of the CVD prevention story, not given as much attention. It sort of virtually dropped out of QOF over the last few years. So GPs have had, there's been less incentive to focus on cholesterol. And of course, as we discussed earlier, I mean, data is absolutely #1 pillar in the population health management approach. If you don't have data, well, you don't know what you're doing and where you're going. And I know you're generating more data through this, the broader AHSN approach. And the CVD Prevent is the new National Primary Care Audit, where we expect data to be on stream by the end of the year, and that will bring us a lot more real-time or virtually real-time data to show us how we're managing in primary care, where the opportunities and gaps are, where the inequalities are. So I think that will, when we get that data, it will help all of us much better to focus our efforts, won't it?
Completely agree. I think, you know, having that information from the CVD Prevent audit will really drive delivery around this agenda. And I think it will help us show the impact of the AHSN programme around lipid management and the AAC rapid uptake products programme. But it's fundamental to showing how we can improve things and look at return on investment.
I feel like cholesterol has always been a bit of a poor relation to AF and hypertension, and this is levelling the playing field with more data through CVD Prevent, with the AHSN focus on cholesterol. It's been a sort of Cinderella part of the CVD prevention portfolio, and I really welcome the refocus on this, because I think we've lost our way a little bit, and as a result, patient outcomes have been compromised potentially.
Yeah, I can't agree more, Helen. You know, I've never understood it. I'm not a GP or a lipid doctor. And you look at the evidence for lipid management and the impact that we can have. And it's really simple and straightforward to manage people's cholesterol. I think blood pressure is far more complicated. So actually, as you've said, this refocus is really welcome. And hopefully over the coming years, the HSN programme, the AAC programmes collaboratively will lead to the benefits that we hope to see.
But I think that's, Julia, what we were reaching to in the programmes that we run before it's adopted, because the why have things not been happening for citizens in the right way is always the right question. It's often one we don't ask is why. Why do the workforce find it difficult? Why does the citizen not understand that they should maximise their lipid lowering? And I think the tools that we've managed to develop, so dropping into GPs' electronic patient records, a search engine to help them, also the communication strategy, also something around implementation being wider and reaching to wider determinants, and actually telling people there is a chance that you could deliver this differently and we will incentivise you to do so. actually all of those pillars are really important to maximising the outcomes that we're reaching towards. And I think that's why we need to go in the NHS, is not just performance manage and say this is really bad to target, but why is it bad and how can we make it better together? So it's really exciting pieces of work that the AHSNs will be leading on, I'm sure, in the future, is really getting the implementation right and the pathways right for clinicians to operate within when they're under pressure.
Definitely.
Sorry, go ahead, Matt.
I was going to say, yeah, this is also so important, and it's really striking. It's really striking the opportunity we have to do things much better. But as you say, Tracy, it's the focusing on understanding why it's not working so we can then improve it. If we do more of the same, we will get more of the same. And we've not really progressed in cholesterol management in the last 20, 30 years, or in more recent years, certainly. So doing more of the same will deliver more of the same. How can we do it differently? It has to be based on an understanding of why it's not currently working. But the overall case, I was really struck by global burden of disease study data, looking at the contributors to premature mortality, and what are the ranked risk factors for premature mortality. And of course, number one is smoking, as one would expect, at around 20%. But what really struck me was to see that blood pressure and cholesterol together add up to more than 20%, or have a greater impact on premature mortality than smoking. That's the sort of rank, or that's where this should be placed, and helps us understand just the sheer impact we can have on population health if we get this right. And I think this is great that we're now developing such a structured approach to getting it right.
What we were discussing very early on that might make you laugh, but we don't want to almost give people an injection to lower their lipids and then they can eat as they like. So it has to be part of an understanding that it's a holistic programme reaching to wider determinants, Matt, as you say. But it's important to discuss that when new therapies, and this may not be the last, this is just an example, how it fits into the pathway that exists, how we then deliver it, how we speak to patients about how they want to see it delivered, and how it would change their lives, but without looking at just lipids, looking also at the same time, to your point, blood pressure, smoking, other indicators at the same time. But it offers us opportunities to do things differently.
I was really struck by your comment, Tracy, about the importance of breaking down silos and silo working. And, if you think about the patient journey, 99.9% of it is spent in primary care, even if they do need specialist input. And to deliver at a population level, we really need specialists to be much more outward looking. I think actually COVID has given us some more opportunities to do more remote monitoring, more virtual consultations, and to bring the specialist in the experience out to support primary care, because they haven't got capacity to see every single patient that needs something beyond a statin. And we need to think about, well, how do we tap into their understanding and knowledge and really upskill that primary care workforce and the broader workforce, which Matt highlighted. We're not just talking about GPs taking on more work, we're talking about the clinical pharmacists, the nurses. How can we bring community pharmacy in the pathway to support patients, and all of those non-clinical roles that are being developed at the healthcare assistant level.
Yeah, you're absolutely right, Helen, about that. And we kind of, in some of our systems, we seem to stop at things like primary care networks, which are just small collaborations. Over the last 5 years, I've led a programme in Greater Manchester about local care alliances, which are about making every contact count for the patient so that they go through a system and care is delivered to them with many people on the same site, many people tuning into their health needs. So involving expert patients, involving physio at the same time, the same place, involving getting the diagnostics done, having the specialist next door to the generalist so that they can work together as a team. And really, if these work so well, we've based it on other models in other countries that have shown real advantage, because the patient feels that instead of going to 10 places for the same condition and having several handoffs, They can visit one place and it's wrapped around the patient, instead of the patient having multiple visits and multiple car parking tickets and multiple journeys on buses to just reach the outcome that we all want them to reach. So why aren't we making it easier?
It is a challenge to configure at that level, and hopefully, you know, your team and the work that you've done in the research study will help support people in localities to work out how they can change their mindset and change their delivery framework to really be, as you've pointed out, patient-centered, holistic, dealing with global cardiovascular risk, both lifestyle and what we might consider as more medical risk factors like blood pressure and cholesterol. So I think we've heard a lot now about the challenge of population health management and the opportunity it really presents to us. What I want to do is hand over to our audience, the people who are listening in, to ask us and ask the panel questions. So over to you all. Thank you for joining us for this session. Apologies for the slight delay at the beginning. There was an issue with the live stream, but I'm glad you all stuck with us. We're planning on having a Q&A session now, and we are getting some questions in. What I thought that we would start with is really a question about the opportunity that the move towards integrated care systems gives us. How can ICSs really make things happen and change the way we do things? Thinking specifically of all the different players. So I'm going to hand over to Tracy with her primary care hat on to think about that first.
Thanks, Helen. And I think it's an interesting question. So how do we deliver on what the nation want to do around population health? And how does the white paper give us the permissions or enable us to do that? So the new ICS white paper speaks more about collaboration than we felt in the NHS before, less about doing individual pieces of work in silos and more about how do we pull the system together. And I think it's essential for primary and secondary care as providers to really come together and make the pathway for citizens seamless, less handoffs and more directed. So how does that work for population health? Well, we first need to define where the data sits and all the resources for data collection that we have, pull that together so that we can see and actually find patients that would benefit from certain treatments and then involve them in that treatment decision, which we can do at various stages in primary and secondary care. In the example we've been talking about in Inclisiran, it will be in primary care, but in some areas, this might also be in secondary care with primary care helping. I suggest that Julia may be able to tell us how secondary care is planning to get involved also, Julia.
Yeah, thanks, Tracy. I'm a secondary care clinician. So, you know, what I think I see the future looking like is much more collaborative, as you say, much more integrated. That everybody takes responsibility for patients wherever they are within the NHS, and we get away from this silo working that we've heard about over the last 40 minutes. You know, I think it's really important to just remember that the NHS is not just in one hospital or one CCG that might be outstanding or it might require improvement. There are NHS patients everywhere and they should all benefit from the best available treatments and the best available evidence. So to me, I think it's about secondary care reaching out, making sure that it's fully integrated with colleagues' clinical pathways that may originate or terminate in primary care, and that to make sure that we don't just see ourselves in secondary care as the people that deal with the specialist things or the things where, you know, the culminations of poor population health management, such as the stents in the heart attack patients or the knee replacement in the arthritis patient. So, you know, we've got to see and realise that everybody has responsibility for preventative medicine, And that's probably one of the only ways that the NHS is going to be able to cope with the current tsunami of chronic illness that we've got, is if we do all take responsibility for the whole pathway. I'll hand back to Helen with that.
But Helen, yes, so just to comment on that, because I think this is such an important discussion and really important to remind ourselves of the purpose of this population health approach and the purpose of collaboration. It's because we do want to have a big impact on the population, and largely through prevention. Cardiovascular disease is hugely preventable, but we also know, and another major reason for working together and collaborating in a population health approach is because of health inequalities. And we know cardiovascular disease accounts for 1/4 of the life expectancy gap between rich and poor. And it's only by getting the data and understanding our population, understanding where we should target our resources, which communities we should engage with and work with to make changes, and who else needs to come on board to address those wider determinants. That's the only way we will have the population health impact. So.
I think the reaching those harder to reach groups is a really important thing we can focus on, and perhaps there are lessons from COVID around this, where we've been suddenly forced to be a bit more outward looking and pulling people in rather than waiting for them to come. Any comments from your experience around how we can get out and link in better with what we might call harder to reach groups for various reasons? I'm going to pass that to Tracy first, put you on the spot, but I'm going to ask Matt and Julia as well for their experiences.
So we've had lots of learning from COVID, and some things where we deeply collaborated together, as Matt and Julia have said. So in delivering, for example, oximetry at home and recording patients that have needs, and able to get to them, reach out to them in their own home, and actually digitally provide plans that can enable their care and accelerate their care should things start to deteriorate. So I think there's examples in that. I think what I've really learned coming from primary care, so sorry to be a little bit more parochial for a second, is that the vaccination programme has told us and taught us quite a lot about how much local primary care can flex and deliver, and actually how they've worked with their wider stakeholders. So they've worked with the local authorities, volunteers, the citizens themselves, to actually deliver something collectively that has enhanced their community and the citizens within it, i.e. they've been vaccinated, which has improved their healthcare. So I think really I want to keep hold of that going forward from COVID, of how we've actually got down on the ground in neighbourhoods or communities of 30 to 50,000, which is easier to do, and really understood our neighbourhoods and been able to co-produce pathways of care at this level, which is not just about primary care, not just about secondary care, but also about social care, voluntary sector, local industry and citizens. If we do this all together, we might have the potential of saving our National Health Service.
Thanks, Tracy. Matt?
Yeah, definitely. I think we all know that COVID, as well as the disaster it's brought, it has brought huge opportunity, and within the healthcare system, within primary care, because we're all primed now to doing things differently. We know we have to. So much has changed, and that makes it much easier to get new things done and for things to happen in a different way. But it is really critical to work through how do we support primary care to do things differently. It's not enough to talk about it and to advise us in primary care to do things differently. And that's certainly been another focus of our approach with developing the proactive care framework. So what are the nitty-gritty individual things that we need to help clinicians and non-clinicians to do things differently? So for example, I mean, and a lot of this has got to involve use of the wider workforce, but we know that to support people with long-term conditions, with CVD or with high cholesterol, to support them to improve their health, they need help with education and understanding their condition. They need support to self-manage, to support for behaviour change. but many people just need support for some much more basic things in life, and the things that add up to whether a person is activated or not. That's a rather clumsy term. In the approach that we've taken, we've identified that those are the things we don't do very well in general practice usually, because we lack the time and we often lack the expertise. So let's use groups of the workforce, people like healthcare assistants, peer workers, health coaches, to take on some of these functions. They can support patients with self-management, teach them how to do their blood pressure and things like that. But they can also use health coaching skills and motivational interviewing skills and listening skills, and listening to what actually matters for the patient. What do I need to help you with today before you can move on to thinking about your cholesterol or other things? So I think it's really important we take a systematic approach to this, identifying in practical terms, how do we make that sort of stuff happen in primary care? And I think we will. I think we've got a huge opportunity now and a huge enthusiasm amongst GPs and their teams to do things differently. But we mustn't just expect them to go forth and do it. We in primary care will need help and structured support.
Yeah, and I think I concur with both Matt and Tracy on that, but I also, from the COVID pandemic, sort of highlight the benefits of having a national network, such as the HSN network, which supports innovation, allows it to be developed and then adopted and spread at pace and scale. So Tracy mentioned the COVID oximetry at home, which the HSN network supported local systems to implement that completely new initiative in a very, very short period of time. And we can do that because we have national reach, but with local influence and local knowledge. So that was put to test with the COVID pandemic and showed that it was able to respond as a network, and with lipid management, including Inclisiran, that innovative change in the clinical pathway around lipid management is something that the HSN network is able to support local systems to adopt.
Great, thanks everyone. Comments come in also about the importance of third sector organisations and community groups in being able to support people, on the ground with behaviour change and lifestyle change. And I guess one thing COVID has taught us is that we can't wait for people to come into us, particularly when people aren't able to come into us during the pandemic, and that actually we need to think about how we can reach out to those groups and utilise them. That, I remember we did some work around blood pressure and AF with Age UK. Rather than expecting people to come to us, we were able to go out to groups of 20, 30 people, meeting together, socialising together, but also an opportunity to support them with their healthcare. So I think we do need to make those links. I guess the biggest challenge, of course, is time and capacity, and hopefully ICS working will enable us to have a bit more time to be more outward facing.
I think it's an opportunity to get creative in that collaboration. So some areas, for example, are bringing together the voluntary sector groups with local health professionals to support people without digital access. So helping people get more affordable access to broadband, for example, helping teach people digital skills to support them to do that. All of these things are the practical blocks, aren't they, to people being able to take control of their health and support themselves. So huge opportunities for creativity.
I do think there's an answer to that question, Helen, from some of our viewers. I'll go back to what Matt said about primary care. It also applies to our VCSE. Let's resource them accordingly, because they are also run on very short contracts. We're unable to plan for future work and actually to become a true provider of some of those services, which we really, really need and certainly value here in Greater Manchester. We need to resource them adequately to take their role in that space. What we have realised with digital in primary care, that we've opened so many more channels for access, and we simply don't have the capacity to respond to all that access. So we do need to work with various other partners in order to meet the demand that's out there, because if we don't meet it, it's just unmet, and was probably unmet before when we just used telephone and appointments. There was a huge unmet need. Now we've got more visibility of the unmet need. We need to decide how we work together to meet that need.
And I guess in the centre of all this, we talked about population health management, is the patient, and how do we help them be more empowered? How do we support them better? How do we give them better access to their own health information and new opportunities to engage with the health delivery system? Any comments on how things have changed over the past few months and how that can potentially help support patients better?
So Helen, I'll start, and then perhaps others will want to come in. But we've been learning a lot, and as we said in the COVID oximetry, that helped us with a handheld app to report in, and it helped to remote monitor patients in their own homes. So what we'd like to do is springboard that into more access into fuller care records that are held and updated by patients as much as they are all their medical and other stakeholders, social care inputs into that care record. One, I'd like the patients have visibility of their care record, and two, they need to be able to input into it, and we need to use their own devices in their own homes so that they can say who their next of kin is for end of life, how they would want to end their days, what sort of provision they would like to be delivered. So, for example, a lot of patients say to me as a GP, I actually would like one person to come and do 10 things rather than 10 people to each do one thing. You know, those sorts of priorities we need the patient input to. But what we need to do is not have 1,000 apps rolling out to our citizens, but we need to control that into a single platform or into their record so that they can do different things, that have easier access, so they've not got 1,000 passwords that they all forget, but actually co-produce this with our citizens to understand their need. And I think we need to do more of that in the health service, is work with co-planning and co-production of strategy with our citizens.
Julia, anything the HSN are doing on supporting some of this work around digital inclusion, etc.?
There are a number of projects going on around digital inclusion, lots of projects supported by NHS-X across the HSN network. The Beneficial Changes Network is looking at projects around remote monitoring and the implementation that underpins some of those technologies. So absolutely, Helen. There's lots of work around shared care records, as Tracy's pointed out, and associated evaluations. If people are interested, then they should contact their local HSN or have a look at the HSN network website, because there are lots of examples.
And COVID has really precipitated a major shift, I think, in the speed by which these things are being developed. Matt, sorry, you wanted to come in there.
Yeah, no, I think it's such an important discussion, and as Julia was referring to there, the implementation support that HSNs can provide is critical. So it's fantastic that we're opening up access to people to use devices themselves, to submit their own data. That will be rich data that we, health professionals can use to support people to stay well and to get healthy. But it won't just happen on its own, and it's not enough to give people an app, as Tracy says, or to give them a device. If people have a blood pressure monitor, they generally will need support to know how to use it properly and submit valid results. They'll need support to know how to send the results in and how often, and some understanding of what the results mean and when do I need to worry about it, what is blood pressure and how do I look after it myself, etc. When do I need to worry about it? All of those things are critical part of the implementation pathway, and no bit of technology or data transmission is going to be of any value unless it's part of that sort of pathway.
Yes. Right. Well, we've actually come to the end of our time. It's been such a great discussion. Hopefully you find it really useful to hear the insights of our three great speakers here. So I hope you'll all go away and put some of these suggestions, tools, resources that we've covered into practice, and enjoy the rest of your day. Thank you very much.